Traumatic rotatory instability of the elbow. Kamal Gokus, Associates Professor, Kent University, Alanya Research and Practice Center. Acknowledgement. This video was produced from the book source that was shown below. We would like to thank editors, Bibatala P., Siebenlist SN, Waddle JP. Citation. Bibatala P., Siebenlist SN, Waddle JP. 2019. Acute elbow trauma fractures and dislocation injuries. Springer. Epidemiology. The epidemiology of elbow rotatory instability is until now not fully understood. The phenomenon of various elbow instabilities as the posterolateral rotatory instability, PLRI, is multiple described, but the pathomechanism for a posterior medial rotatory instability, PMRI, could not be simulated until now. Especially the classification of Regan and Maury could not identify the combined injuries of the fracture of a coronoid and ligament ruptures. Posteromedial rotatory instability, PMRI, was first described by O'Driscoll et al. In 2003 as anteromedial fractures of the coronoid, AMC, and lateral varus instability. After acute trauma, these fractures are often missing because of their rarity. Moreover, associated to coronoid fractures, they often look subtle, like terrible triad injuries. This might lead to poor clinical outcomes. Further teaching in diagnostics, understanding of the rotatory pathomechanism and treatment must be trained to reduce the rate of the insufficient outcome of the PMRI and PLRI, respectively. Pathomechanism. As the elbow is such a stable construct for rotatory instability, severe valgus, PMRI, or varus, PLRI, load is needed. The mechanism of posterolateral rotatory elbow instability is described in detail in the chapter Simple Elbow Dislocations. In case of a valgus overload of the radial collateral, the ligament will rupture, and on the other side, a concave fracture in the anterior coronoid can be seen. This leads to a PMRI. G. King described the pathomechanism for the anteromedial coronoid fracture, O'Driscoll type 2, occurring by pronation, varus, and axially directed forces. It is accompanied by avulsion injuries of the LCL and the posterior bundle of the MCA. Injury to the anterior bundle of the MCA can also occur with anterior medial coronoid, AMC, fractures and will enhance elbow instability. In case of a varus overload of the lateral ulnar collateral, the ligament will rupture, and, in some elbows, a convex fracture of the anterior coronoid rim can be seen. If seen in chronic cases, the ROM might be reduced, or the picture of a stiff joint can be found. Clinical signs. In acute trauma, the patients have a free range of motion with an unstable feeling when testing them with light varus or valgus resistance. There might be hematoma medial and lateral at the joint. Sensomotoric deficits are very seldom but have to be securely excluded. In chronic cases, patients often describe persistent pain and cannot remember any previous trauma. Clinical signs. Because of the brief history of realization and published AMC fractures, the incidence of associated injuries is not well known. The partial or complete injuries of the LCL are common, and the amount of injuries to the posterior bundle of the MCA is uncertain. As is well known in terrible triad injuries, there is a fracture of the radial head, but not in patients with anteromedial coronoid fractures and a consecutive PMRI. So, this is a fact to differentiate and to detect the PMRI. Clinical signs. As published by G. King, the PMRI should be suspected in any patient who appears to have an anteromedial coronoid fracture when a radial head fracture is not present. The following clinical examination should be verified in the case of suspected elbow instability. Clinical signs. The PLRI testings: valgus stress test, intensifier in 0 to 30 to 60 degrees, draw test, pivot shift test, pincer grip test, push-up test. The PMRI testings: varus stress test, arm lift-up test, intensifier. Associated injuries. The associated injuries depend on the severity of the trauma. The isolated ligament rupture, especially LCL, up to a terrible triad injury. The frequency of an injury to the posterior bundle of the MCA is not well documented. In varus/valgus injuries with rotational instability, even the wrist has to be investigated to detect further instabilities. Classification: PMRI classification, coronoid fracture classification. In the publication of O'Driscoll et al., 3 anteromedial coronoid fracture subtypes are differentiated. Subtype I involve the anteromedial rim only, subtype 2 involves the rim and tip with a concave fracture line, and subtype 3 involves the rim, and sublime tubercle, with or without the involvement of the tip. Figure. PLRI classification. The PLRI can be classified after O'Driscoll according to the grade of the joint dislocation between 0 and 3. No statement can be given about clinical instability. Geyer et al. Published an arthroscopy-based classification. Because every ligament can be separately tested, this gives a highly differentiated diagnosis. Symptoms and diagnostics: signs and symptoms of posteromedial rotatory instability of the elbow, PMRI. Every injured or dislocated elbow must be examined in detail for neurovascular injury before and after reduction. The status of soft tissue and the condition of the skin should be carefully assessed and documented. Also, careful palpation for signs of tenderness, particularly over the LCL, mucal, and lucal is recommended. If a patient complains of crepitus within elbow motion, the arm in valgus stress abducted from the side, this might be cartilage crepitus due to maltracking in varus PMRI. Signs and symptoms of posterolateral rotatory instability of the elbow, PLRI. Besides the mentioned common examinations in injured elbows, the PLRI shows specific symptoms in clinical examination tests like the pivot shift stress test, the draw test, the push-up test, and the relocation test of the elbow. In the acute phase, the patient reports instability and weakness in elbow valgus stress situations. In the chronic phase, some patients show the symptoms of radial epicondylopathy, and in a later phase neuritis of the ulnar nerve can be seen. Rotatory instability, imaging. In the acute trauma X-ray in AP, lateral views, radiograph, and if there is a painful region around the radial head, a targeting picture or the radial head is recommended. If clinically indicated, X-rays of the shoulder, forearm, and wrist can be made. After the reduction of elbow dislocation, the standard X-ray of the elbow has to be repeated. Findings can be subtle, such as loss of a parallel medial ulnar-humeral joint line, or varus malalignment of the elbow. Rotatory instability, imaging. The radiocapital joint may be widened with LCL disruption, and a fake fragment from the lateral condyle may be visible. CT scans, Figure 2, with 3D reconstruction, Figure 3, improve the recognition and understanding of the pattern of anteromedial coronoid fractures and are recommended routinely in the evaluation of these injuries. Rotatory instability, imaging. The use of the MRI in these cases is still under discussion. In acute trauma, if promptly available, extra information about muscle lesions can give the treatment indication. In chronic cases, the stress test under ultrasound vision is also recommendable. Injury pattern and surgery-related anatomy. The combination of LCL injury and an anteromedial coronoid fracture showed in biomechanical test a fragment size depending on instability. G. King recommends the internal fixation of the lateral ligament and the coronoid fragment if larger than 2.5 mm. However, we have seen severe complications in patients with only ligament repair, and we, therefore, also recommend reconstructing or to buttress small coronoid fractures to give the elbow more varus stability. The stability of the sublime tubercle has also to be controlled. Discontinuity of the sublime tubercle is often combined with MC instability and has to be surgically addressed. Therapeutic options. Non-operative treatment. The conservative treatment of PMRI and PLRI depends on several factors. In international literature, there is no clear recommendation for or against it. If there is no continuous dislocation of the elbow, the coronoid fragment is small, and the patient is compliant, non-operative treatment can be initiated. An ultrasound or intensifier examination can clear the indication. Large coronoid fragments, additional muscle injury, continuous subluxation, or dislocation require operative treatment. Sometimes a CT scan shows a joint incongruency not seen in the X-ray. Anteromedial coronoid fracture. The non-operative treatment of anteromedial coronoid fractures starts with a 90 degrees elbow flexion cast with the forearm in neutral rotation for 1 week. Passive motion out of the cast once a day with the help of a physiotherapist is recommended from the beginning. After 1 week the patient gets an orthosis for the daytime with a limitation in the individual stable arc. The patient should actively start with extension and flexion without weight bearing for a minimum of 6 weeks. A cast is still a good option during the night. Anteromedial coronoid fracture. Passive motion out of the stable arc should be done by the physiotherapist. If crepitus occurs, the diagnostic must be focused, and surgical treatment might be needed. Because of a varus moment on the elbow, the abduction of the arm should be avoided. Further, we read in the book of G. King that pronation stabilizes the LCL deficient elbow, and supination stabilizes the coronoid deficient elbow. Hence neutral rotation is selected for flexion and extension exercises and for immobilization. Anteromedial coronoid fracture. We recommend weekly clinical and X-ray control to monitor fracture displacement and ROM. A reduction of the ROM and/or a subluxation/dislocation is an indication of an operation. The patient shouldn't practice with load until the full range of motion, or the 12 weeks isn't reached. Anteromedial coronoid fracture. In the literature, the information regarding the outcome of non-operative PMRI of the elbow is low. Dornberg and Ring reported on 18 patients with anteromedial facet fractures with an average follow-up of 26 months. 3 patients had non-operative treatment, 2 had an excellent outcome, and 1 fair. Because a fragment malunion may lead to persistent subluxation and secondary osteoarthritis for which there is currently no good reconstructive option, we prefer in most of cases the surgical treatment. Surgical treatment PMRI. The indication for surgical treatment is given in patients with a non-concentric elbow, displaced anteromedial coronoid fracture, and fracture fragment interposed in elbow articulation. Under anesthesia, the elbow stability can be tested under an intensifier to prove the collateral ligament instability and fragment dislocation under load. Surgical treatment PMRI. For patient positioning, an arm table can be used. The posteromedial rotatory instability injuries of the elbow are best approached with a medial incision. Here for a high shoulder rotation of more than 90 degrees is needed. As an alternative, the injury can be repaired with the arm placed across the chest. Surgical treatment PMRI. For preoperative planning, a CT scan is helpful for fragment size and number. The main fragments like the medial facet and large anterior coronoid tip fragments must be addressed with a stable osteosynthesis. We recommend using 2.4 mm interlocking plates and screws for radial head and coronoid. After the osteosynthesis, ruptured ligaments, LCL, must be fixed by suture anchors, in our hands 2.5 to 3.5 mm diameter. If the sublime tubercle is fractured, we also fix it with suture anchors. 1.6 and 2.0 mm K-wires are also needed. Surgical treatment PMRI. The surgical approach to the coronoid fracture is described as anterior or medial, figure. If only the ulnar side must be done, we prefer in the acute traumatic situation the medial access. To reach the LCL and the radial head Cocker's approach is recommended. The ulnar nerve must be located safely. If preoperative ulnar nerve symptoms are documented, a decompression of the nerve and if needed a ventral transposition should be done. We also recommend doing a transposition of the nerve in cases of medial ulnar plate osteosynthesis. Surgical treatment PMRI. The best approach to reach the anteromedial coronoid fractures is the interval between the heads of the flexor carpi ulnaris muscle. By using this approach, sublime tubercle and MCA can also be reconstructed. For the reconstruction of the coronoid tip subtype 2 fracture, the flexor pronator muscle has to be detached from the medial epicondyle plus the supracondylar ridge. Temporary fixation with K-wires allows the final osteosynthesis with cannulated screws or interlocking plates after control of the position with the intensifier. Because rigid fixation is needed for coronoid fractures, suture fixation is not recommended. Figure. In the next step, the LCL stability is tested with the intensifier under mild valgus stress. If the joint gap opens wide, more than double, a reconstruction will be done over Cocker's approach, Fig, and the ligaments can be fixed with suture anchors. Figure. The stability will now be tested in mild valgus and varus stress tests under an intensifier. If there is residual instability, an external fixator can be used. In acute trauma in the PLRI cases, there might be a rupture of the LCL and LUCL. Sometimes a convex fragment of the medial coronoid can be found. This is biomechanically discussed as a pushed-out fragment. Cocker's approach and a split between the extensor carpi brevis and the anconeus muscle gives a good visualization on the subepicondyle region. If possible, the ligaments can be reconstructed by a baseball stick and a suture anchor in the isometric region of the lateral epicondyle. Figure. Surgical treatment of posterolateral rotatory instability. If a coronoid fragment is present, it either must be removed or fixed to prevent medial instability. The instability can be tested with mild varus stress under the intensifier. The operation technique is like the PMRI treatment. Postoperative care. In the OR, the elbow is placed in a 90-degree splint with immobilization of the wrist in the intrinsic plus position. On the first postoperative day, the passive mobilization out of the cast by the physiotherapist begins. The cast must be worn for a minimum of 5 days. After that, a moving orthosis can be used for 6 weeks. We recommend using the orthosis by day and the cast by night until the first 14 post-op days for faster reduction of the edema. First 2 weeks ROM in extension/flexion 0 to 20 to 90 degrees and no pro or supination. 3-4 week ROM in extension/flexion 0 to 10 to 110 degrees and free pro or supination. 5 to 6 weeks in extension/flexion 0 free and free pro or supination. Outcomes and complications. After stable fixation of the coronoid fragment, complications is rare. Non-rigid stabilization leads to subluxation and destruction of the elbow joint. The ulnar nerve reacts sometimes sensible to contact with plates or screws. That's why in these cases a transposition is recommended. There is a limited number of case reports in the literature about PLRI and PMRI injuries and treatment. Dornberg and Ring published a retrospective review about 67 elbow dislocations with 11 patients having a varus posteromedial instability. Another study by these authors presented 18 patients with anteromedial facet fractures of the coronoid and in 12 cases excellent results after stable anatomical fixation of the fragments. Conclusion. PMRI and PLRI are rare injuries and have not to be missed. Surgical treatment is a good option for excellent results if a stable anatomical fixation is reached. Thank you for watching this video. This video was produced from the book source that was shown below. We would like to thank editors, Bibatala P., Sieben List SN, Waddell J.P. Citation. Bibatala P., Sieben List SN, Waddell J.P. 2019. Acute elbow trauma fractures and dislocation injuries. Springer,